uh, Durga Rani, and I should be talking on a study on posterior segment of risk factors in closed globe injury with hyphema patients.
Good morning all. I am going to present a study on posterior segment risk factors in closed globe injury with hyphema patients. Introduction. Ocular trauma is the leading cause of preventable visual impairment and blindness. Blunt trauma of eye can lead to various intrinsic ocular injuries. Hyphema is defined as blood in anterior chamber, which is a common manifestation of blunt trauma. Severity of damage is directly proportional to severity of trauma. Blunt impact force in closed globe injury leads to coup and counter-coup injuries resulting in posterior segment sequelae, which are associated with poor visual outcome. Objective of my study is to determine trauma-related posterior segment risk factors for poor visual outcome in patients who presented with hyphema following a closed globe injury. It is a prospective observational study conducted in Government Medical College, Kottayam in patients presented with hyphema following closed globe injury during a study period of 1 year in 48 patients. Those who presented with trauma-related posterior segment risk factors in hyphema patients following closed globe injury in the age group of 18 to 60 years were included, excluding with those with pre-existing ocular diseases and with history of previous ocular trauma and surgeries. Study procedure. Patients with hyphema following closed globe injury satisfy inclusion-exclusion criteria were taken and best corrected visual acuity is graded, and pupillary examination is done to look for RAPD, and slit lamp examination is done to look to grade the hyphema, and indirect ophthalmoscopy is done to look for retinal tears, macular hole, vitreous hemorrhage, Berlin's edema, choroidal rupture and hemorrhages. If media is hazy, B scan is done to look for RD, CD and vitreous hemorrhage. Appropriate medical and surgical treatment is given wherever possible, such as IV methylprednisolone, pars plana vitrectomy, buccal and Barrett's laser. Visual acuity is assessed after 6 months. Best corrected visual acuity, if it is more than or equal to 612, is taken as good outcome, and less than or equal to 618 is taken as poor outcome. A total 11 patients presented with vitreous hemorrhage. Out of 11 patients, 8 patients had good outcome, 3 patients had poor outcome. Total 6 patients presented with traumatic optic neuropathy. All 6 patients had poor outcome. Out of 8 patients presented with retinal detachment, 3 had good outcome and 5 had poor outcome. Out of 15 patients presented with retinal tear, 11 had good outcome and 4 had poor outcome. Out of 8 patients presented with macular hole, 5 had good outcome and 3 had poor outcome. In my study, 90% of the patients were male, mostly in the age group of 26 to 40 years. Most common mechanism of injury was assault followed by workplace injury. Most common risk factor was retinal tear followed by vitreous hemorrhage. Poor visual outcome in my study was traumatic optic neuropathy followed by retinal detachment. In Jakarta eye trauma study, poor outcome was due to vitreous hemorrhage and choroidal rupture. In Koje et al. Study, poor outcome was due to macular edema, epiretinal membrane and choroidal rupture. In Jaiswal study, poor outcome was due to vitreous hemorrhage, macular hole and retinal detachment. In Kalfan Ali et al. Study, poor outcome was due to macular edema and macular hemorrhage. Conclusion. Trauma-related posterior segment risk factors are the major contributing factors for poor visual outcome in patients presented with hyphema following a closed globe injury. Early recognition of factors related to poor visual outcome, timely appropriate medical therapy and surgical intervention when indicated, and careful follow-up helps in preserving vision. Wearing protective goggles at workplaces helps to decrease ocular morbidity. These are my references. Thank you.
Your primary inclusion is hyphema. So irrespective of hyphema, traumatic optic neuropathy or RT will have the same kind of outcome. Will hyphema have a bearing on the outcome? Number one. Number two, due to hyphema, was there any glaucoma? Was there any blood staining? So those things also matter, isn't it? Hyphema is your primary finding, but you are given outcomes of the associated findings. You didn't talk about what happened to the face. You are given all grades of hyphema, including age for life. So So was there anything there where you had to intervene for hyphema, or you're not intervened, was it glaucoma or anything like that? You're not mentioned in your study. Hyphema outcomes you're not mentioned. No, I'm just asking you. Only the associated features outcomes you're seen, isn't it?